I had the idea for this presentation about a year ago, primarily because people outside of the eating disorder world, I believe, don't really appreciate, because I didn't, I'm thinking for myself anyway, my experience is I didn't appreciate the importance of dietitians, and especially in eating disorder treatment. When I was training, my residency and general medical training, the dietitians kind of did diabetes education for patients and so on, but I never really interacted that much and knew how to utilize them in a team of psychiatric treatment. In any event, I'm a psychiatrist and an addiction psychiatrist, so coming to Rosewood 8 years ago, the dietitians taught me everything I need to know about eating disorders, quite honestly. And ultimately, my respect for the profession, especially in working with eating disorders, just grew and grew and grew exponentially in a very short time. Eating disorders work in many areas of psychiatry, community mental health, psychotic disorders, and a variety of addiction and so on, but the toughest population for me to get inside their head was eating disorders. And the people that helped me quite a bit was our dietitian staff, our RDs, and our therapy staff that had experience with it as well. I have this running joke in our facilities that it's easy to be a psychiatrist in the first couple of weeks of eating disorder treatment for somebody coming into treatment, because I just put my feet up on the desk and let the dietitians do all the heavy lifting. Because really it's about getting people back into some sort of nutritional state so their bodies and brains are working okay before I can even diagnose psychiatric illness. If you don't have the building blocks for neurotransmitters in your diet, you're not going to have enough neurotransmitters in your brain for my medicine to even work. Because as you know, psychiatric medications don't replace what our brain makes itself. They enhance what's there. So if you're not eating a diet that makes enough serotonin, norepinephrine, dopamine, acetylcholine, all these chemicals that operate our brain, I can give the person all the Prozac in the world, but it's not going to make their serotonin system work any better or more optimally if there's not the precursors there to put serotonin together so that these drugs work. So my experience, again, as I worked in eating disorders, it's kind of similar to addiction, because I did this, the research was very clear in addiction 20 years ago. You bring somebody in to addiction treatment, and 2 weeks later, their psychiatric symptoms look a lot different than the first day that they show up in treatment. I still see people overdiagnosing psychiatric disorders early on in treatment because somebody's using uppers and downers and they're diagnosed bipolar disorder. That really doesn't make sense to me. What I was taught years ago was that you give the brain a chance to heal and then you try to do an accurate diagnosis. Same thing holds true for eating disorders. A couple of weeks of a good nutritional meal plan, and oh my gosh, that depression, that anxiety, all the kind of symptoms that people show up in treatment with tend to settle down. So I learned, again, in my time working at Rosewood, that the message that I give from the time the person walks in the door, or that I meet the person, is food's the best medicine. Listen to the RDs, do the meal plan. If you do it 100%, what that does is gives me as a psychiatrist the opportunity to make an accurate diagnosis. If you're fooling around with your meal plan, you're just delaying the opportunity. If they're looking for drugs and they think they need medication for depression and so on, if they're not doing their meal plan 100%, not restoring their brain's chemical balance, if you will, it's a simple way to look at it, then, I don't know what I'm doing with my medication. So I put this together to, again, highlight our very talented nutrition staff and to be able to give folks an appreciation as to how it's important for me to have a good dietary staff that can restore people to a state of nutrition that then allows me to be an adequate psychiatrist, if you will, or to take care of people the way they deserve. Gosh, I don't like this. Can you hear me okay if I'm not on the mic? Yeah. It's recording? Oh, jeez. Was it coming through when I wasn't standing right in front of the microphone? All right, I'll put it back in here.
Put it on the other side.
What's that?
Put it on the other side.
Okay.
It works.
again, as I've come to learn, I never got this in residency, psych residency, even much of it in medical school, that I remember when, in my younger days, we used to hear the statement, "You are what you eat," but it's really true when it comes to your mental status. Because I've seen folks coming into treatment that look like they have Alzheimer's disease, 25 years old. Sure, I'm a geriatric psychiatrist in a previous life and worked in geriatric centers diagnosing dementia. These folks would come in and be markedly underweight and have short-term memory deficits that look very similar to Alzheimer's disease. I said, gosh, this is really unusual for somebody this age, but it's probably due to malnutrition. Occasionally you'd get a CT of the brain if they had neurological issues and the brain looked like an 80-year-old brain. It's just shrunk. When somebody's malnourished, the brain takes a big hit. What's interesting is a month later, after their restoration starts happening, it kind of pops up into shape again and starts to work the way it's meant to work. But again, very interesting in observing the patients that I treated early on to see these phenomena and have to understand that it was due to the nutritional state. I didn't rush to a psychiatric diagnosis until the person got more normal in the nutritional state. Again, very similar for those of you who work in addiction. Don't rush to a diagnosis of bipolar disorder until you have a brain that's free of drugs and alcohol for 3 to 6 months. I mean, that's really, if not longer, until you can come to an accurate psychiatric diagnosis. So I went to this lecture, maybe 3 or 4 years now, given by a woman who was a PhD in both pharmacology, psychopharmacology, neuropharmacology, and nutrition. And she put together this lecture that says, this is what you have to eat to make a neurotransmitter. And a couple examples are up there. Acetylcholine, you need to eat eggs and dairy products. I don't know the details about this, or the nutritionists would know much better than I. So imagine eating a diet that's completely void of the substances to make acetylcholine, which is the key neurotransmitter deficit in Alzheimer's disease. We know pretty clearly that the acetylcholine-producing cells die before the rest of the brain dies, which is the onset of Alzheimer's disease. I said, wow, it makes sense now. If they're not eating enough food to make acetylcholine, they're going to look like they have, Alzheimer's disease. And then when you restore the diet with those building blocks, the memory returns back to normal because now they can produce acetylcholine. It's not that it's an age-related death of cells. The other one that was very interesting to me is GABA, gamma-aminobutyric acid. It is the only and primary inhibitory neurotransmitter in our brain. Every other chemical in our brain activates a process of some sort in a cell, in a brain cell, in neurons. GABA, throughout the whole brain, modulates that. So you're not overly excited, you're trying to balance correctly. You get enough excitement and then it balances and brings you back. If you don't have any GABA, you're going to have seizures. Your electrical activity is going to be out of control. If you don't have enough GABA, you're going to be anxious and nervous and really look mentally ill, potentially. And I like to put it's our internal balance, it's our own internal tranquilizers that our brain makes for ourselves to keep us calm. What you need to create GABA is glucose, carbohydrates. What I learned in the first few years of working with eating disorders is now that carbohydrates are the bad foods, since Dr. Atkins, has been around. It used to be fats before that. I'm old enough to remember when fats were the bad foods. But now it's carbohydrates. So people preferentially, the young people we see coming into treatment, preferentially restrict carbohydrates. And I would notice early on, and it still is true today, that they had these cluster of 3 symptoms that were very consistent for me. High anxiety, insomnia, and headaches, which I believe they call them migraines, but they're muscle tension headaches because they're so wired. I believe in some ways it's induced by the fact that they're not eating enough carbohydrates, and what's again really interesting to me is to sit back and wait a couple of weeks for the food to work. All of a sudden the anxiety gets better, the sleep returns to normal, and the somatic complaints of headaches and tension ease up quite a bit. So do I have proof to say that this is exactly the cause? No, but it makes sense to me as I put the pieces together of what you need to eat to what you need to do to make the brain work right, to see this so consistently that I believe that people are inducing syndromes in themselves based on eating a certain way when it comes to eating disorders. And people with eating disorders eat in extreme ways that are hard to imagine sometimes. So, bottom line is, I put my feet up and turn it over to the dietitians and say, fix the nutritional state for these people, and then I'll start paying attention to what might be left behind, and might be something that I need to consider an antidepressant or some other mood stabilizer or whatever that might be necessary for somebody with comorbid conditions. People with eating disorders, you hear the experts say have an average of 4 diagnoses. So they'll have an anxiety disorder, a substance abuse disorder. At Rosewood, in our inpatient setting, most common co-occurring condition is depression, but major depression. And after a couple of weeks, though, a number of those folks are better just by nutrition. And if it lingers beyond that, we'll often use an antidepressant. Second most common is substance abuse, either flat-out addiction or pretty significant abuse of multiple substances. So we always have to take into consideration that we're looking for other psychiatric diagnoses. But it takes time, and it's important. I've learned it's important to be patient. We do often get enough time to let people's brains restore nutrition to make an accurate diagnosis. And I do believe at least a couple of weeks before you're going to get a picture of what might be a comorbid condition that requires more psychiatric intervention or medication. I see people showing up on every class of psychiatric medication known to man. And then some, on doses that are unimaginable for somebody who's 75% of their ideal body weight or less, on maximum doses or beyond of antidepressants, antipsychotics, benzos, unfortunately, a lot of benzos. And it makes sense if people are depleting their own GABA, they're going to be looking for external GABA, which are the benzos, to make themselves feel better and don't even realize that that's what they're doing. So at Rosewood, I've learned again, and I was taught by some really good addiction psychiatrists years ago that I spend more time taking people off medication than putting people on medication. Those of you that were at Dr. Pohl's lecture last night, that he talks about the miracle of seeing somebody come off opiates and the lights come back on and so on. Again, it's the exact same thing that I see in eating disorder treatment. Number one, you enhance their brain with nutrition. And number two, you get the poisons out of the way so they can start thinking and feeling the way they were intended to. Then comes the hard part of doing the trauma work, is once they start feeling that stuff again, that's really important that you follow through and do the work, the family of origin work, but you can't do that when people are stoned on mind-altering substances when they come in for treatment. Most psychiatrists, most medical doctors, most psychotherapists don't have much experience with eating disorders. So that's how this happens. I really truly believe doctors aren't evil and they're not looking to overdose people on medications, but they're looking for something to be helpful, and somebody describes a symptom, so they use a drug that works in another disorder for the similar symptom, thinking that might help, and it just builds into a very confusing state of what might be helpful and what might not be helpful. Again, I was taught by docs that said, if you got the time, and I trained in a state hospital setting where we had months to work with patients, so I really saw this work. You take people off the stuff, see what you have, and then see if you really need to use medication in an effective way. So, again, my experience with medication is to go slow and go low dose, average dose. Many patients will come in that do have a major depression, if you will, that they are appropriate for an antidepressant medication, but for example, they're on 80 milligrams, the top dose of Prozac, when 20 milligrams works for 90% of the people. So by the time they might leave Rosewood, we've got them down to 20 and leave them at that point, because more is not necessarily going to work when you don't have enough neurotransmitters, enough serotonin for them to be effective anyway. I talked about this a little bit already. Pretty much stuff, basic stuff. Acetylcholine is the memory neurotransmitter. GABA is the anxiety neurotransmitter. Serotonin, norepinephrine, and dopamine, primarily mood regulatory chemicals. And I do believe, as I said, food is the best medicine. Your brain is going to make it when you eat. People talk about supplements. There's GABA supplements out there. My understanding is they're just digested by the stomach anyway. The GABA and these chemicals that operate the brain are made in the brain. So the building blocks have to get through the blood-brain barrier where the manufacture happens. So you can't take external supplements for GABA and expect it to make you less anxious. Perhaps you can take the building blocks for GABA, which is really just carbohydrates, if you will, in your diet, and that ultimately, if you're not taking it enough, should help the GABA production. And with that, I'm going to turn it over to Helen and talk about the nutritional aspects.
All right, so what do dietitians do while Dr. Karp, while Dr. Karp apparently is sitting in his office with his feet kicked up? Yeah, I'd like to bust into his office and catch him one day. You'll have to, I just want to start off and say, you'll have to excuse my over-enthusiasm. I've been working in an outpatient setting for the last 9 years and returning back to the inpatient setting. So for me, this is instant gratification. I think for us, we rarely ever see instant gratification with our clients, but being in an inpatient setting, I get to witness, and I feel so honored that I see a client come in a very compromised state, physically, physiologically, emotionally, psychologically, and through a couple of weeks even, they start to come alive, and all of a sudden, you know, their personality comes, their wit, their sarcasm, unfortunately, you know, and they're like a totally different new person. And then, you know, usually by the third, fourth week, when we have possibly the medication is starting to kick in, you know, they just come alive, and it's a very beautiful thing that I feel very honored in an inpatient setting to be able to see. Even though it's an inpatient setting, it's still very important to individualize the client's needs as much as possible. But there are consistencies on the way that I treat the different diagnoses, and I'm going to kind of walk you through the different diagnoses and what we do. The primary goal for someone with anorexia would be obviously to refeed and to help them restore a healthier body weight. Clients with bulimia nervosa, it's about restoring you know, a lot of things that are not working properly in their body. And for a client with binge eating disorder, formerly known as compulsive overeating or bulimia nervosa without the purging, it's about trying to teach them how to rebalance their nutrition again. The definition of malnutrition, what does mal mean? Bad. It's badly nourished, whether they're undernourished, overnourished, or they cycle pretty rapidly between either extreme. This is what we're dealing with. So clients with anorexia, they have a low body weight, and you know, depending on their body mass index, depending on how they were previously eating, we start them off at a pretty low calorie intake. As unhealthy as it is to lose weight too rapidly, it's extremely unhealthy, and you know, they could get even worse medically if they gain weight too rapidly. And so in the outpatient setting, if I saw clients gaining 1 to 2 pounds a week, that's as good as it gets. But in the inpatient setting, because they have the constant supervision medically, they're able to restore a lot quicker, and anywhere from 2 to 4 pounds. On average, I would say my clients gain about half a pound per day. So they're able to restore a lot more rapidly. Oftentimes, we might start them as low as 1,000 calories. This sounds very low to maybe you and I, but to this population where they're possibly eating even less than 500 calories, that's a pretty significant amount already. From that point, we start to increase it maybe every 2 to 4 days, around 300 calories. As much as possible, as much as their body could handle it, we try to encourage more calories. Let's see, tube feeding. We do have the capacity and capabilities of tube feeding, but this is something I use as a last resort. It does help them restore the weight that they need. However, it doesn't teach them how to eat, which is, you know, a very important goal. So for clients who are very resistant to treatment and refuse or unwilling or unable to eat through mouth, then that's when we'll, you know, talk to them about the advantages of tube feeding. But even with tube feeding, we try to do it for minimally maybe about 2 to 3 weeks, and try to get them off of it as quickly as possible to try to teach them how to eat again. Am I doing that by any chance? Okay. Am I stepping on a magic? Clap on. Okay. We got this. We got this going on. Okay. I feel like dancing all of a sudden. Supplements. The use of supplements. I would say about maybe 90% of clients with anorexia will need to be on supplements at one point or another. Even though we're starting them off at about 1,000 calories, at one point because of their hypermetabolic state, supply and demand. We supply our body less, it demands less. Supply and demand, we supply it more, it demands more. So all of a sudden, their body goes into overdrive, and their body needs these calories. So I have clients up to 5,000 calories a day still losing weight and swearing up and down that they're eating everything, and I'll believe them half the time because I do believe that they're showing symptoms of this hypermetabolic state. Their body is using everything they're getting. So supplements is very useful because even though we feed them about 6 times a day, if you're eating 5,000 calories, that's a lot of food to intake. So because of that, we're trying not to trigger a binge, purging behavior or them feeling like they're binge eating. So supplemental drinks is very helpful for that. And then I kind of use it as insurance as they get closer to their goal weight, rather than taking away their food, because now they're going to have a sense of deprivation. I'm just going to take away the fluids that they're drinking, and then they're going to get on a more maintenance meal plan. So we monitor them medically. I work very closely with the psychiatrist as well as the medical doctor to make sure that their lab values are improving. A lot of them are off. Their kidneys are not functioning. Their liver enzymes are off. We see this with alcoholics a lot, but as well as people with undernourishment as well. Their electrolytes are very imbalanced. There's quite a bit of clients with anorexia or bulimia. There are laxative abusers. I see clients that use on average 25 to 150 laxatives a day. Talk about a pain in the butt. Can I say that? It is. I have one client, for example, she's almost 5 feet tall, and for the last she came in at about 55 pounds, and she was using about 100 different laxatives a day for the last 10 years. It's almost a miracle that she could go at this point. She's on about a 5,000 calorie meal plan, and at this point restoring very slowly. I think she's closer to 90 now. But again, we almost celebrate, and I want to throw her a party every time she has a bowel movement. She calls them bowel babies, and she gets really excited about that. Let's see. So their electrolytes are going to be very imbalanced. Their potassium might potentially be low. I see this a lot with clients with anorexia who also are either underhydrated or overhydrated. So our bodies are made up of 60% water. So water weighs a lot. And so because of that, some clients restrict fluids because it makes the number on the scale lower. And so again, that could even throw off more lab values, make them orthostatic, or their blood pressure drop too low. And then I have my water babies, hydrophilic, water-loving clients that are trying to compensate for eating by drinking copious amounts of water. We recently had one that was drinking, when you drink so much, what happens is your sodium level dips so low, and when that happens, there's an accumulation of excessive fluid in your brain, which presents itself as psychosis. So I've had one male telling me about these sexual thoughts he's having, and from the voices, and I'm like, what voices? And he said, the floating head behind you. Kind of looking over, there was no floating head. And again, we have this other client that we had to take her water bottle away. We had to carefully monitor her. We even went so far as to unhook her water in her bathroom, but she was still trying to drink on her faucets. And the staff would try to stop her, and she's like, "I'm not drinking," really, truly, wholeheartedly believing that she wasn't. Sticking her head in there drinking more water. So, again, hydration and water balance is extremely important with this population. So protein is in everything from your head to your from your hair falling out to pedal edema from having excessive fluid accumulate in your feet. And so protein is an extremely vital food group for this population. So even the ratio of nutrients that clients need has to be carefully monitored. Again, the general population, we recommend, the American Dietetic Association recommends, 55 to 60% of your intake from carbs. But with this population, it needs to be lowered, although I think Dr. Karp aged himself as well as I'm about to, that in my day it was fat that was the greatest fear food. With this population, it seems to be more carbohydrates now. It still needs to be the basis of their diet, so it's about 50%, but then it's going to be equal amounts, about 25% protein to 25% fat. You know, for healthy people, we need maybe about 10% protein, but these clients, whatever their body weight is, that's around how much protein they need. Yes?
What's the example of the carbs that you feed what are carbohydrates that you feed in this kind of setting?
That's a great question. Thank you for that. And again, we want to promote healthy eating, but for this clientele, healthy eating is being able to eat bagels and donuts maybe, you know, because they have such a fear and they put so much power in these foods. So, you know, again, part of the reason I really do enjoy working at Rosewood is we have that variety, and as much as we want to promote whole wheat pasta, whole wheat couscous, quinoa, all of these are healthy eating that, you know, all of us should have more in our diet. However, it's very important, and it's part of our philosophy to incorporate croissants and white pastas as well, and to give them an array of different carbohydrate sources. You know, bread is now more fearful than even butter for a lot of these people. So we do have whole grain breads as well as white breads, and it's trying to incorporate that variety that they've really limited for a while. So, you know, we have clients that are very, the reality is we want to try to get whole grain bread, but we won't in certain functions. You know, you might go today and there's complimentary sandwiches on white bread. You know, there's a difference from food preferences and food fears. And if it's a fear, you're empowering that food, and until you take that power away from it, it's still going to more than likely set you up to relapse. So thank you. That's a great question. Yes?
How much water intake did someone drink to cause their sodium levels to drop?
That's a great question. And again, it depends on what the size of their body we're talking about. For us, the general population, for every calorie you consume, you should have 1 milliliter of water. So if the average intake is 2,000 calories, we should have about 2 liters of water per day, which is equivalent to 8 cups. Now, mind you, half the fluid we get is through the fluid we drink, but the other half is through the fluid we eat, through carbohydrates and fats, which is another thing that they've been restricting for so long. So they're, you know, they have a double whammy effect of dehydration, even though they may be fluid overloading. So, you know, I would say definitely 5 gallons a day. I've seen clients do that. That would do it. So maybe if they should be taking about 2 to 3 liters a day, which is 8 to 12 cups a day, if they're doubling that, then we could start seeing this effect. And with this population, again, they're under-eating, so they're not eating dietary sodium chloride, so it also exasperates all the negative effects of low sodium levels. Okay, great question. You guys could just chime in. I like the questions. Okay, so as I mentioned, we have to compensate for their hypermetabolic state. We kind of, you know, in addition to their labs, which oftentimes it gets worse, like their anemia gets worse before it gets better sometimes as their blood volume shifts. You know, other signs that I ask them very casually to see if they're experiencing this is night sweats. You know, again, their body is going into overtime in you know, processing. In order to make calories, we need calories. So the average person, maybe 5% of what you eat goes to burn what you ate. For this population, it could be 15 to 20% of what they eat goes to burn. So they get really hot. You know, they produce heat. And so, you know, they'll wake up 2 or 3 times in the middle of the night having to change their shirts because they're drenched. You know, this, again, is a symptom that they're really experiencing, that hyper-metabolic state, because their metabolism, the rate in which you burn food, if it's here, when you supply it less, it drops. So you almost shoot yourself in the foot, where you can be eating 15 to 2,000 calories to maintain your weight. Now you're training your body to, you know, to gain weight at eating 800 calories because your metabolism has slowed down. And then they go into a state of overdrive for a while. And that could range anywhere from, you know, a couple of weeks to the most severe case. I saw someone in a hypermetabolic state for almost 6 months. You know, she was on 5,000 calories and still dropping before your body comes back to normal, and depending on how resilient your body is. So let's see. Another aspect with this population, anorexia, is oftentimes part of the definition, the diagnosis of anorexia is they lose their period, amenorrhea, because you need body fat as well as dietary fat, because fat plays a role in sex hormones. So oftentimes they lose their period, and you know, statistically it takes about 6 months of being at your natural, healthy body weight for you to get your period back. But what I've noticed is periods, sometimes it's the first to leave, sometimes it's the last to come back. There's no rhyme or rhythm. Very rarely do they experience it, unfortunately, because of the short amount of stay that they stay in the inpatient level. But sometimes I am, again, this is something where I feel very grateful to be able to experience when the client does get their period back. That's a huge thing. For them, it means I am fat now. I'm eating too much fat, and it's, a lot of clients who might not be ready to be an adult now have to experience that. I personally think we should have a I am a woman party for these, or at least present a red rose, but I'm still trying to fight my staff on that to celebrate it more. But teaching them, this is where it's very helpful to have therapists in-house to really help process it. What does it mean to be a woman? 70% of people in the inpatient level may have some sexual trauma, so it could be very traumatizing. So that's something else that, I give them education on what that means and how beneficial it is in helping them to get a period regularly, such as, preventing osteoporosis, because when our body needs calcium, and when you're amenorrheic and you don't have your period, it leaches the calcium from your bones into your blood. And so because of that, there's a huge population. I've had clients in my private practice as young as 14 with osteopenia. But at that age, the good news is they're able to restore it with proper nutrition. I've seen their bone scans, and it's a miracle, and it's wonderful to see. Did you have your hand up?
Yes. I actually was wondering what the impact was of someone losing their period and not having it for a long time. It sounds like that's obviously
that's a huge thing, is that they have bone loss, and then it also could come. I don't say this too often to scare them, and again, sometimes I do to motivate them. I think on a good day, my best role is a cheerleader. Happy fingers, I'm cheering for them, trying to encourage them to eat more. But the reality is sometimes it leads to infertility too. Yes, with any significant weight fluctuation, whether it's weight loss or weight gain, a loss of period or irregular periods can happen, and it's when they get back to their natural body weight. Again, malnutrition is being either under or over. Eating disorders are the same, it's just different diagnosis. But yes, with that clientele too, clients with binge eating disorder who have gained a significant amount, when they get back to their natural body weight, I usually see that their periods are more normalized as well. As far as the bone loss, I think it's less dramatic for a variety of reasons, because of with the anorexic population, not only is it leaching, they're not eating calcium sources. Whereas clients that have binge eating disorder might go through bouts of binging on ice cream and other calcium-rich sources. Okay. So with clients with bulimia, even though they come from a phase of, depending on where they are, under eating or overeating, we still can have the luxury of starting them off at a higher calorie level because of the binge eating behavior. So with an anorexic client, we might start as low as 1,000 and go up to 5,000. A client with bulimia will probably start them off at maybe about 1,500 for maybe 1,800, give them time to adjust. But by the time they're ready to discharge and they're at a healthier place, they might only be up to about 2,400. So the calorie range is, going to be different for someone with bulimia. And this might be very shocking, and again, this helps when you have someone with, experience with eating disorders. They're going to experience weight loss. Why? Because they're binge eating 10,000 calories a day just before they came. So, again, trying to monitor that and, catch it before they lose too drastically. It's very typical that the first 5 days to 7 days, usually by the 7th day, I'm going to say, okay, I think this client's ready to increase, their meal plan. It's very tricky and sensitive, because if I do it too soon, then I might be encouraging them to start the vomiting behavior. So I give them a little time to adjust, and then gradually increase to what's more appropriate. We monitor their electrolytes between laxative abusers, but also through vomiting. Vomiting or diarrhea, your electrolytes are imbalanced. Do you ever go running and you get a cramp in your calf? What do people tell you? Eat a banana, right? Do you ever hear that? Because potassium plays a role in muscle contraction, right? What is our heart? It's one big muscle. And this is where it becomes very lethal, because when your potassium drops so low, your heart could go into cardiac arrest, and that's what leads to death. So we monitor their electrolytes to make sure that it's balanced and they're healthy. We use Pedialyte often with clients, even with, when they come in detoxing from drugs or alcohol too. Our standard protocol is to have Pedialyte given 4 times a day because it's a very concentrated source, more so than Gatorade, of electrolytes, so it helps them restore it quicker. This population, more so than anorexia or binge eating disorder, possibly will need some bathroom monitoring, whether that's depending on how motivated they are or how honest they are. It might just be a fellow peer, or it could be a staff with them 24/7 trying to make sure that they're not engaging. We might have them make sure that they, go in a hat to make sure that there's no vomit in there. So it's really trying to minimize that, because the longer they go without vomiting, the harder hopefully it's going to get to vomit. So bathroom monitoring is important for this population. Gastrointestinal problems. There's such a large majority of clients with every diagnosis with irritable bowel syndrome, which is exactly that. Your bowels are irritated, especially with this population where they're vomiting constantly. It really can mess up their whole GI system that goes from your mouth to your anus. So there's a lot of different issues going on, which is very legitimate. So again, if you see a non-eating disorder client with IBS, the protocol is to have minimal fat, to watch the types of fruits that they eat, like no fruit juices, so it's limiting their diet even more. So it's trying to balance between getting their medical needs met and really validating that we know that medically there's stuff going on, but also trying to get them over their fear foods as well and not creating more fear foods. Gastroparesis, when they have that, or delayed gastric emptying, this population, when they're diagnosed with that, they could vomit 5 hours after they ate a meal, pretty, a significant amount. So again, watching for that, esophagitis and different tears in the esophagus from acid reflux, all of this is happening too. So addressing their medical needs is very important, because they may not trust you, if you don't believe that they're experiencing medical things. Let's see. Stabilizing their meal plan. With this population, all of them are very black and white, but it takes them a while to get it. The cycle of a binge, of someone with bulimia, is restricting throughout the day and then binge eating at night, or restricting for a couple of days and then binge eating for a couple of days, and then going back to the cycle over and over again. So sometimes I sit down and I do the math with them. Okay, so 3 days a week you're telling me you're eating about 500 calories. And then 2 days a week you're binge eating on about 8,000 calories. And then 2 days a week you have a more reasonable amount. And I'll literally do the math for them and say, okay, so what you're saying is that if you eat X amount of calories, you're maintaining your weight anyway. So how about we start you off at somewhere a little bit lower, and have a little bit more sanity instead of going from one extreme from day to day. And they're like, oh, that kind of makes sense. Let's try that. So it's really working with them and challenging their very distorted beliefs. With this clientele, we really try harder with all clients. You try to de-emphasize weight, because that's the question they want. Sometimes I think that's all they think I'm there for, is to talk and discuss the weight. There's never a right answer for them on if they've lost weight, even though they need to gain, they're disappointed. If they stay the same, they're disappointed. If they gain, then they're upset. So we try really hard not to discuss weights and numbers with them. But towards the end, and for this population, even if they're slightly underweight or overweight, the goal might not be to focus on weight loss or weight gain. It's just about really restoring their body and getting it to normalize. But towards the end, I start to gently talk about what their natural body weight might be, because the ideal they have in their head is when they're at the worst of their disease, when they're binge purging crazy or they're restricting, and so they have this illusion that they're going to be 110 pounds, when after a while I get to understand their metabolism, and I could pretty much kind of predict a more natural body weight for them, and I start to just start that gentle dialogue. And in an inpatient setting, again, when I piss them off and they start crying, I'm like, okay, go to your therapist now, and go to Dr. Karp to get some medication. So clients with binge eating disorder, so these clients come from binge eating thousands and thousands of calories potentially, and then the moment they step into treatment, and even the night before they come into treatment, you know, the last hurrah that clients have before they go to even drug and alcohol treatments, we see this with eating disorder clients too. They come in and then they see me on day one and say, okay, I got to lose weight. And they get into this whole black and white mentality of all of a sudden, I had this client recently who's saying, oh, I didn't eat the bread, you know, that's bad. And I'm like, sweetie, you were binge eating on 4 pizzas, you know, the day before you came in here, and now 2 slices of bread is bad, you know, and it's all or nothing. And I'm trying to help her realize that she's setting herself up to fail with that dieter's mentality. So it's more of a lifestyle that we're trying to do. We're trying to build a solid foundation, you know, so they can go on and do the work. And if part of their recovery, it might be weight loss and to be healthier for it, it's not like we're dissuading them from that, but just focusing on the basics and trying to get, it's not about weight loss, it's about being healthier. And for some people, reality is weight loss will be a side effect of it. But I try really hard to discourage clients who would benefit from weight loss on focusing on it, because they're more likely to fail, you know. Setting realistic weight goals. Now, I know that research says that clients with binge eating disorder, 40% meet the the classification for obesity, but in the inpatient level, in order to, I guess, be to be approved by insurance, they have multiple things going on. So I see a higher majority of clients at this level with binge eating disorder who are at a morbidly obese or, you know, class 3 obesity number. And so because of that, we work a lot with adjusted ideal body weight versus, you know, just the BMI or ideal body weight that other clients might be using. And then, you know, again, I talk to them about that towards the end, about setting realistic weight goals. So these clients oftentimes have other medical issues going on. Diabetes is a very common diagnosis, which again, it's not about, even with diabetics, you know, my mother's diabetic, it's not about not eating carbs. And it's not, of course it is the type of carb you eat, but also the timing of it, and it's trying to balance it throughout the day, which I think for everyone, diabetic or not, would benefit from eating more consistently throughout the day. It helps with your blood sugars being stable, as well as your moods as well. So it's trying to re-educate them again. High blood pressure is a very common another diagnosis. And now in the last 5 years, I'm seeing such a huge trend with clients who have had bariatric surgery. I used to, in my private practice, counsel pre-bariatric patients, and you know, it sounds kind of counterintuitive to my specialty with eating disorders, but I honestly felt that, you know, it could help potentially people, but I want to make sure that they understand the ramifications of it, that the surgery will alter their stomach physiologically. They'll be able to eat less, but emotionally is a different story. So we see all these clients who, you know, they think it's a quick fix to have bariatric surgery, and then, you know, but they've never addressed their emotional aspects of eating, so they're still binge eating, and then they have a lot more medical complications from that. Yes?
What's the instance of seeing alcoholism post-bariatric surgery?
You know, that's a good question.
Repeat the question, please.
I asked what was the incidence of seeing alcoholism increase post-bariatric surgery?
Yeah.
Instead, as high as 40%.
40%? Okay, that's good to know. I didn't know that, but again, I'm glad that we do have a number, so, yeah.
Well, oftentimes, from what I understand, is it really takes less for them to get intoxicated.
Yeah.
Their stomach is smaller, and then their coping mechanisms are to self-medicate, so they can't do it because of food dumping or whatever.
Mm-hmm.
Then they oftentimes might be turning to alcohol, and it's like a transfer addiction.
Which is so common, isn't it? You know, we have clients that give up the cocaine, meth. It always comes in cycles, I think, when in the inpatient level, and so they go from one drug addiction, you know, one addiction to another. And so with eating disorders, you know, it's like, I'm not minimizing by any means, you know, clients who are struggling with alcohol issues or drug issues, but, you know, you can be black and white. You either drink or you don't. But with eating disorders, you can't be black and white. You still need to nourish your body, hopefully more than 3 times a day. So I just kind of envision like a recovering alcoholic who still works at a bar and hangs out with friends who drink and lives above a liquor store, I couldn't imagine telling an alcoholic, could you drink in moderation, 3/4 of an ounce of vodka, 3 times a day. It's just really, really challenging. So I have a lot of empathy for clients with eating disorders struggling through this on a daily basis. Promote mindful eating. So this is another thing that we really do with the clients with binge eating disorder. Every time I meet with them, I ask them, how hungry were you before breakfast? Extremely hungry, hungry, ready to eat, not hungry at all. After their meal, I ask them the same questions. Content, satisfied, very satisfied, full or over full. Their hunger fullness scales are so off. All the populations are. But, with this population, it's really trying to get them to honor and their satiety scale, and believe it or not, I encourage them to eat to the point of feeling satisfied, because I feel when your needs are met, you don't need them as much anymore. So when you do eat to the point of feeling satisfied or even very satisfied, you're more likely to be at your natural body weight. People think that you can't. You have to be, half starved to get to this weight, but that's not the reality. Physical activity, with this population, because of their weight sometimes, they have all these orthopedic problems as well, physical activity is not only not functional, it's not fun as well. So trying to reintroduce activities that are appropriate for them, such as swim workouts. It takes a lot of the pressure off their joints. So I'm there, cheering their mom by the swimming pool, hoping nothing happens, because I'm not the best swimmer, although I'm CPR certified. I was born and raised in an island surrounded by water, and I never learned to swim until I went to college in Alabama. So with all types of eating disorder, it's constantly about trying to normalize their intake and incorporating that variety. We limit the amounts of dislikes that they have, and really challenge their food fears on a regular basis. And then nutrition education, it's education. There's so much information out there, right? Isn't that part of the problem? We read so much and hear so much, and because of that, clients have all this wealth of information, but using it to hurt themselves versus helping them. The rainbow way of thinking, this is where I get a little bit cheesy, but between black and white, there's a spectrum of colors, and I try to encourage the clients to find their rainbow way of thinking with food. This is where I lift my foot up and say, I'll lead to your pot of gold. And then again, like I said, physical activity, we have clients with exercise bulimia and over-exercising, and so really trying to get them to see it as, there's a fine line between obsession and dedication. And if you're a dedicated exerciser, more power to you. But when they cross that line, it personally makes me sad. I have my master's in exercise science, that when you cross that line, all of a sudden exercise becomes a punishment versus a reward. And trying to really, that's another part that's kind of like, we're working on the ABCs of, their issues. That's probably a little bit further down the road and should be addressed more in the partial level of care. So, yes?
So as far as like challenging the distorted beliefs about food, what about, I'm sure this is more in line with the binge eater, like emotional overeating.
Uh-huh.
How do you address that, or does that get more addressed with a therapist?
Right, both. So, again, there's a lot of overlap. And again, if I feel like it's more of a therapist's responsibility, I let the clients know. But constantly, you're trying to give them information and educate them and challenge their beliefs in different ways. And there's different nutrition experientials that I do with different populations we'll talk about later with that. So bottom line is, I went through all this, but inpatient treatment, it's to get them medically stable, potentially restore to a healthy weight. You're better able to manage or understand behaviors. Again, I don't know how many of you guys work with eating disorders, but in the outpatient level, when I ask a client, how often are you vomiting, and they say once a day, then I add 3 to it. If they say they're taking 5 laxatives, then I add 5 more to it. So, again, if they're eating 2,000 calories, then I take off 500 calories from that, or add 500 calories to that. So in an inpatient setting, they're contained. So when it's reported by staff they're eating 2,000 calories, then I'm pretty sure they're eating 2,000 calories plus or minus 100. With bathroom monitoring too. If they're purging, at least we know exactly how much they are, so we're able to help them even that much more in that setting. They're able to trust their meal plan because, in the outpatient setting, I could tell them 1,000 times till we're both blue in the face that if you could eat this and you won't balloon up, but they don't believe it. But in the inpatient setting, they are eating it and they're not ballooning up, and I want to do my I told you so dance. I had some of this, some of that. Apparently it's immature of me, I had to stop. But they're able to really trust the food and trust the process and then deal with the emotional aspects of their their eating disorder. Okay, so I think at this point, Dr. Karp is going to talk about some of his lessons.
Kind of rehashing. I do believe that until the brain is nourished again, I shouldn't mess around with powerful medications that we have available to us that are very effective. One thing that people don't understand or don't think about, I guess, and when I give our lecture to the family program and the families come in, is that any study done for a drug on the market currently is a very clean and sterile study. What I mean by that, if somebody came into a depression study and had an eating disorder, they'd be excluded from the study. So all the drugs in the research setting that we know about that's being studied for depression, we don't really know how they work in an eating disorder because that person would have been excluded from the study. So we're extrapolating the drugs that are approved for treatment in a very specific one disorder person is going to work in people with multiple disorders and addictions and so on. So I'm always amazed to think that we ask, why isn't this working in this certain population? But in real life, when there's multiple things going on, we never really controlled for that all that much to get these drugs on the market in the first place. So when somebody's malnourished, that would have excluded them from the study, so I don't even know if I can rely on Prozac, which is a good antidepressant and actually the only drug approved for treatment of eating disorder of any type. So I'm always skeptical about that. Okay, I know it's in this setting, but I'm not sure that it's going to translate, and again, I see docs trying to do that with very high doses in ways that end up being more harmful by side effects than beneficial. I do believe that in the same fashion that my years of working with addiction, with addicted patients, has served me very well in eating disorder patients because, for example, I take a young man who's coming out of a rehab and has a very classic major depression with the genetics in the family. You wouldn't question it. It's a comorbid condition. And they're coming into my office and I'm prescribing the Prozac, for example. I don't have any investment in Prozac. Of course, it's generic now, so it doesn't matter. Still a very good drug. Always will be. Once that kid starts drinking again, I don't even worry about whether he's taking the Prozac or not. My whole goal is to get him sober again, stop drinking, and then I can expect that my medicine's going to have an effect. But if they're drinking, we know very clearly that it negates the effect of antidepressants. So why would I even talk about that? My whole goal is to get them back on the recovery track. Somebody goes off their meal plan, somebody starts binging and purging again, it's exactly the same phenomenon. So one of the things that I talk about is when people are leaving intensive treatment, they should be meeting with their dietitian a couple times a week. Because once the meal plan falls apart or the behaviors start again, nothing I can do. I really believe that, except be the cheerleader to get them back on track. Just like that alcoholic, I want to get them to meet 3 meetings a day after only doing 1 meeting a day and they're drinking. Same thing holds true with eating disorder folks. If they're not doing their meal plan, or they're binging and purging again, or they're restricting, they wouldn't be doing the meal plan. That's the whole focus of treatment. Because once you get containment of those behaviors, they can stay on track. And you can't do therapy work if you're acting out your behaviors, because you leave the therapy session and then you go numb yourself with your binging and purging or restricting or exercising or whatever. It's just like the alcoholic leaving a therapy session and going to the bar and getting drunk. What good was the session in the first place? So the goal is to contain the behaviors, let the emotions bubble up, and then we can treat folks. So again, early in treatment, my job is to educate the patient to this effect. We see, again, people coming in a lot of mind-altering substances. And I believe, I'm kind of a PMLD disciple, I believe underneath most addictions is codependency, and codependency comes from family of origin work. And that's what we do in all our programs, is ultimately get to the core issues. Because if you can manage your uncomfortable emotions, you don't need these other behaviors to numb yourself. So that's where we're trying to get to. So the first stage of treatment is I'm getting the benzos out of the way, I'm getting any mind-altering substances out of the way. People come in with chronic pain, we got to get the opiates, we got to get people off Suboxone, off all of that stuff if they're really going to get recovery from their eating disorder and their comorbid addictions. Assess PTSD from traumatic. Again, this is the codependency issue, trauma and abuse, whether it's abject physical sexual abuse, whether it's being neglected by parents and they were a sensitive kid. We still got to search for where's the pain underneath that requires such a drastic method of numbing, which is an eating disorder or a chemical dependency situation. And again, you don't have to have classic PTSD to still have those family of origin traumatic experiences, early life experiences to affect you. So subclinical form, meaning you don't meet the DSM criteria, but you still have traumatic experiences that lead to numbing and the need for self-medication. So big part of all our programs are, I'll be sitting in treatment team and it's pretty obvious when we're hearing the story of a patient that there's a traumatic issue that they haven't come forth with. And I'll say, what's the trauma? I'm always asking the team, what's the trauma? And eventually, you guys with experience know that you can feel that in patients that you're working with that don't even admit to it in the beginning. Yes, ma'am?
My name is Sherry. We worked with two of my clients this year, and they literally came back to different people in terms of this work and my ability to really...
Good, I hope. It was good experience. Different in a good way. I wonder what...
No, different in a good way. Specifically relevant to what you're speaking about right now. They came back with insight and awareness about what the drivers were. They came back completely weight restored, off of a zillion medications, but most importantly related to what you're talking about right now, with access and insight into what had been driving their behaviors and their comorbid conditions. And they did not have full-blown PTSD. And that was what was making them really nuts, was they felt like a traumatized person, but they didn't have a specific traumatic event that they could put their finger on. And their team in Inpatient helped each of them realize that it's okay. You didn't have to survive 9/11 or an earthquake, or you didn't have to be molested to have a variety of these symptoms.
That's why I like Kia's definition. Trauma is anything less than nurturing. So you get a sensitive kid that feels like they're ignored by their parents, and the parents don't even know that. To that person, it's traumatic. So we're always looking for that stuff, and it's amazing how you'll find it.
They're still working and they're still growing.
Great.
It's only because of what you guys did. By the
Thank
way,
you.
He didn't hear me say that.
Didn't plan her. But Dr. Brewerton's be speaking. He's done a lot of work on the relationship between PTSD and eating disorders and trauma and so on. So you might want to catch his lecture, because when I found his literature, it really helped put together how we need to approach this in our eating disorder treatment settings.
One quick question. What about genetic predisposition? I mean,
Yes.
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 Okay, good enough.
In anorexia, 12 times greater risk if you have a close family member with anorexia. Bulimia is about 7 times. Binge eating disorder, I'm not familiar with any stats yet that are out on that. That's going to be in the formal DSM this time around instead of the appendix. There's more research happening. I think you'll see the genetic linkage to that become more clear. But we know with anorexia it's 12 times, and they're doing a major genetic study right now, and there's 12 university settings that are collecting vials of blood from family members with anorexia now that the human genome is identified, to try to find the various genes that are implicated.
So what's the prevalence of an eating disorder in people of lower socioeconomic status and prevalence?
Same rate.
So
It's not a rich
rate,
white
so
girl's disease, and we realize that.
And across the bounds.
Yes, and if you go in and you look for it, you find it. But because there's so many other priority issues in a lower socioeconomic group, those folks aren't coming to aren't coming to the attention of people in the way that it comes to the attention in more I want to say less stressed cultural groups, maybe.
And same thing with like ethnicities, white,
Yes.
black,
Yes.
Hispanic, Asian,
Yes.
across the board.
Yep. As far as integrating treatment, I'm a addiction psychiatrist that's always worked in mental health settings where I treated the addiction with the mental health issues. The research back to the 80s and 90s, very clear. Integrated treatment works better than parallel or sequential. Both groups have to come together and work with people in the same team if people are going to get better. I used to talk to patients back in the 90s when I'd see them go from one system to the other, and each side was telling them something different. I don't know how people got sober and mentally healthy based on the confusion that was created just by having that disparate symptom. If you have a mental health condition, you have a much higher risk of a mental health issue of an addiction, and vice versa. They're interrelated in that they affect each other. Cause and effect is not as important as recognizing that interaction and treating it effectively. I mean, again, the core issues for the eating disorder are the same core issues for the chemical dependency issues. So we're, again, treating it in the same setting is the most effective. We have in-house all 12-step meetings and so on throughout the day. We have a very passionate group of recovering alcoholics. They can have their own meetings in the morning. We have time that they can establish their own meetings outside of when we've created time for meetings and so on. And the latest literature shows that 30% of people coming into CD treatment have eating disorders. So if you're working with people with chemical dependency, start figuring out how you're going to screen for eating disorders, because a full-blown third of your patients are going to have some form of eating disorder when they show up in treatment. Again, medications, what I've learned, get the meds out of the way. Benzos do the same thing as the eating disorder does. It numbs you. And again, I've spent most of my career taking people off these drugs, not putting them on it. I believe I can treat most psychiatric conditions, including anxiety disorders, without benzos much more effectively. The SSRIs work very well. But we have a culture now that feels like they shouldn't feel. Dr. Pohl said that yesterday. I agree with them, that we shouldn't feel discomfort in any fashion, and if we do, we should medicate it. Benzos are contraindicated in eating disorders. I see people coming in, they're on Xanax. That say, why did your doctor start Xanax? Again, this is a non-eating disorder doctor. Says, well, I told my doctor I get nervous before I eat. And my first thought is, well, duh, you got an eating disorder. Of course you do. If you're afraid of snakes, you get nervous when you see a snake. It's common sense. But anyway, the doc would start a Xanax 30 minutes before they eat. And I said, did it help you eat? And if they get honest, sometimes they won't be honest and say, oh yeah, because they want to stay on it. They want to stay on meds that promote their eating disorder, help them live in their eating disorder. But if they get honest, it's like, well, no, it just made it easier not to eat. I guess you have to have some level of anxiety if you're going to be able to push through even in an eating disorder. So we get the benzos out of the way. They're also contraindicated for those that don't know. In PTSD, I still see patients coming in with very significant trauma that are taking high doses of Klonopin and Xanax. And when the research is very clear, you can't overcome your PTSD if you can't have access to your emotions. They're contraindicated. They make people sicker with PTSD. So again, I educate patients, let's get the benzos out of the way. What's underneath your eating disorder is all this trauma. We've got to treat your PTSD, and we can't do that if you're anesthetized from your emotions with tranquilizers. These folks are terrified because they see these medicines keeping them glued together for so many years. Just like the opiate chronic pain people think that, oh my God, I'm going to die if I don't have my opiates. But with education and encouragement, it's amazing to see them willing to do this, and then, just again, like Dr. Pohl said yesterday, you see the lights come on and they're feeling so much better when all these mind-altering substances are out of the way, they come back to life. I've had a couple of patients that were also on opiates for chronic pain. We finally got them off, and I give them Dr. Pohl's book, and they read it, and we get them off it, and they are hugging and kissing us by the time they leave the treatment program. So it really does. I've seen the miracles of people going off meds to understand how important that is. Stimulants are a problem because they're diet pills. I remember when I was probably 10 or 11, my mom would go to the family doc and get Black Beauties to start her diet when it was pretty well accepted in the 60s and 70s. Then we realized people would use this stuff. Well, now we have this new cultural craze of ADD, so we're seeing these drugs reborn in Adderall and Ritalin and so on and so forth, as if they're safer than the drugs that were used for appetite suppressing. Basically, they're all amphetamines, speed. But the folks with eating disorders like it because it kills their appetite, helps them lose weight better. They'll come in and tell their patient, their doctors, they have AED, and the doctor will prescribe Adderall or Ritalin. So got to get those out of the way too, because if you don't know when you're hungry, a big issue of what the dietitian staff is teaching is the mindful eating. Are you hungry and are you full? Well, if you're taking a pill that blocks your appetite, it's not going to be your long-term recovery is going to be in jeopardy. Topamax is another drug. It's so powerful in its weight loss component because not only does it kill your appetite, it makes you feel full faster. So this drug came out probably over 10 years ago for a certain type of seizure, Topamax topiramate. Learned early on it had this effect on appetite. It worked really well for some people with migraines. We had a dietitian once that had terrible migraines. She was put on it. She lost 20 pounds. She came up to me and self-divulged. She said, don't ever put a patient on this in eating disorder treatment, doc, because I'm trying to eat, trying to maintain my weight, and I can't do it on this drug. So folks, again, patients will come in, the internet's out there, they're telling each other, get your doctor to put you on this drug and it'll enhance your eating disorder. So another drug that really you have to get out of the way before people can start to see recovery. The reason it's popular in eating disorders is because about 10 years ago there was a case report came out about 5 or 6 patients with bulimia that lo and behold it reduced the bulimic behavior for a month. You never saw the drug come out getting approval for bulimia, which tells me the drug company probably started to research it. It didn't work. They never came out and said it doesn't work. So you'll still see doctors using it based on those old case reports written years ago, but no real supportive evidence in the long term that got it approved for the treatment of bulimia. Now I will pass it on to Helen.
So I focus more on the inpatient treatment, and as I mentioned before I came back to the inpatient setting, I worked at the outpatient, and I worked at UC Berkeley in their health services with their clients with eating disorders. So I saw probably about 200 clients a semester I was working with. We would probably newly diagnose close to 100 each semester. And what I noticed is the clients that I would send off to treatment, the ones who came directly from inpatient settings back to school were so much higher likely to relapse than the clients who transitioned from the different levels of care. So, you know, I truly believe in the different levels of care and what they could provide for clients at different levels. In the outpatient setting, dietitians are really trying to work with the client to, first of all, just continue the meal plan. Staying clean and sober, you don't want to get in relationships and, you know, focus on your recovery for a year. I encourage my clients to focus on following their meal plan for a year, and that's their sobriety. You know, to really don't think, just do. It's important to introduce the concepts of intuitive eating and mindfulness eating to really try to get them to trust themselves again. But so, I'm sorry, the first year, don't think, just do. Be a recovery robot. Just eat your meal plan so you could deal with all the stressors in your life, because it's not if it happens, it's when it happens. So they hopefully that meal plan is going to be one of their strongest tools that they could use as a crutch when they're not doing well. So we try to, you know, in inpatient we get a lot of criticism from the clients, especially the ones with exercise bulimia, that we don't emphasize activity too much. But the reality is once they leave treatment, they're going to be a lot more physically active. So we do make adjustments and need to, but ideally we're going to do it slowly so they're not shocked and they continue to follow their meal plan. Clients get very overconfident, like I said, and they're like, okay, I'm ready for intuitive eating. I know how to do it. I can eat when I'm hungry, stop when I'm satisfied. How many of us in this room do that? You know, always eat when you're hungry. You know, how about holidays? What happens there? You know, what if the cheesecake tastes really good and we want a little bit more? You know, it's a process. It's a lifelong process, and it's never going to be perfect. You know, the difference with us is that you know, we may not have eating disorders, so it's okay, and we don't go into this whole shame spiral if we do slip up once in a while. Did you have your hand up?
Yeah. How do you incorporate the family into you know, what you're describing?
Right.
If the person is in a relationship or if they're a teenager or, you know, just how does that
Great, that's great. And in the inpatient level, we do have family week when the client is ready and appropriate. We do invite the family, and I do spend time with the family to educate them because, you know, he was talking about trauma, and I think a lot of these family members go through this trauma too, and sometimes it's almost setting them up if we don't educate them as well, because any signs or symptoms they see of their loved one struggling, they're going to jump on them, and sometimes, you know, it's not their job to be the food police, and there's more friction in the relationship. So educating the family is extremely important. Even in my private practice setting, I totally was all in favor of clients bringing in their loved ones who support them, whether it's their parents, their loved ones, their siblings, you know, to educate them on how best to support them. And sometimes it's more enabling if you walk on eggshells, you know. If a client vomits, they need to be held accountable and clean it and replace the food in the pantry. You know, and the family members sometimes are overly sensitive about that, you know, and they oftentimes will buy the diet foods for their loved one, thinking at least they're eating something, but sometimes they're doing more hurt than they are good. So that is a great question. I think it's really vital for the family to be involved.
You know, explaining it's for alcohol, but the principles are the same. And there's a book that we always recommend too called Surviving an Eating Disorder, A Guide to Family and Friends, written by 2 psychologists. The best book out there, you know, to help families not enable but be supportive.
What's it called?
Surviving an Eating Disorder, A Guide to Family and Friends.
I know it's at our booth. We have it up at our booth too. Yeah, if you want to take a peek at it. Let's see, and then another challenge in the outpatient setting is that clients will start to compare themselves to others. I just went to Family Week on last week Wednesday, and a client was talking about her husband being a trigger because of, you know, the fact that he's a male, he's larger, and he eats the same amount as she does. And, you know, again, I'm like, don't compare yourself to others. You got to just focus on yourself, and it's really challenging for them not to. So it really could be a setback. Nutrition experientials at every level of care. This is the fun thing, and this is the, you know, why I sort of miss the outpatient setting. Things like restaurant outing, although sometimes that was more Chinese torture number 3, taking 15 anorexics to a restaurant, and it's especially fun when they're pyromaniacs or hypochondriacs. I mean, kleptomaniacs, yeah, and they're stealing condiments and everything. But it's a really important aspect, and this again in the partial level and the IOP level is where they work on to really normalize, because this is what you do in real life. You go to restaurants, you know, you go grocery shopping. I mean, clients having full-blown panic attacks by, you know, the beef, and you're okay, you're trying to calm them down. In different levels of care, both inpatient and outpatient, sometimes I have them carry around a binge basket. So in a very, you know, indirect way, I'll ask them when I meet with them what were their top binge foods, and sometime during the treatment, especially when they feel like they're ready and I'm all healed, I'm recovered, I'll have them carry around their binge basket full of the foods that they were binge eating on for 72 hours usually, and see how they handle it. You know, I'll take the time to open each wrapper with them and have them smell the food, you know, and see how it goes. And, you know, there's a lesson that's always learned, I believe. You know, and things like that. I'm not just being mean and ugly. There's a purpose. There's a lot of things to do as a dietitian working with a client. I remind myself and I remind my clients every day, I am not a therapist, I'm a dietitian. You know, there's a lot of overlap in the sense that sometimes they feel the dietitian is a safe person to present information, you know, which again, I immediately go to the doctors and let them know what the information, and working as a treatment team is extremely important. But I'm not a therapist, you know, that's the therapist's job, and I just try to really focus on the food and support them there. So there's a lot of experimentals that go on, and then I rock their world and I just send them off to their therapist. So as I mentioned, unfortunately, clients that do need that level of, the higher level of care that aren't able to receive it, the outpatient can be challenging. You know, of course, it's better than nothing, but, you know, we just don't see as successful weight restoration as quickly. As I mentioned, in the outpatient, 1 or 2 pounds a week is as good as it gets for an anorexic. You know, in the inpatient, it's doubled that. Meal support is extremely important. Our clients in the inpatient setting have a staff member sitting with them, you know, at every table, where they point out EDBs, eating disorder behaviors, eating too fast, too slow, cutting their food, ordering their food. I heard recently a client who, I don't know if it's so much eating disorder or OCD, but he alphabetizes food. So he had to eat the apple before he ate the, you find some interesting things. I always learn something new every day. In the outpatient setting, there's always constant triggers and setbacks, and again, there's always the distractions of food, of family members, of school, of work, that really makes it a lot more slow. Again, progress is still there, but it's just a lot slower at the outpatient setting if they don't have a foundation for recovery. Okay, and then any other questions before I turn it to Dr. Karp to sum it up? Yes.
Where do you stand on sugar? I mean, as an addictive food.
Right. I do acknowledge that, that some clients are more sensitive to sugar, but again, I don't believe in putting any foods in any category. It's all about moderation, and I do understand and respect when clients do feel that, sugar is bad, but I educate them, and they'll prove me right 10 out of 10 times that if you try to avoid it, eventually it's going to lead to relapse. So again, they need the carbohydrates if they're really fearful of just sugar. I don't think sugar is bad, to answer your question. If something is naturally grown, I'm very hesitant to think of it as a bad thing. So it's just all about moderation and trying to find a balance with it. So if they're really fearful of that, again, it depends. They're probably not ready to be challenged with it, and then I'll find other ways to get the carbohydrates in. Yeah.
Could I ask before you switch?
Yes.
Have you seen, because I know it sounds like you do work very well with therapists. But as a nutritionist, have you noticed in that binge basket a correlation between the type of binge food and the trauma related to it?
Sometimes we do, yes.
I've seen a lot. When someone tells me they have ice cream or dairy, no doubt, and I don't judge them, I don't put that on them, but in the back of my head, I'm thinking mama trauma, mama attachment, and then breast milk. Yeah. And no doubt, usually when we go back to it, someone that was either not breastfed or has that severe neglect from mama issues. So I'm wondering about
Yeah. There definitely, again, and I know there's some studies on it, but this is another group that I run. I run the nutrition experiential groups, and like food and mood, I often ask them what the foods that they binge on are, and I've noticed this, that, clients who tend to want rich, creamy, soft foods, ice cream, brownies, they tend to be more depressed. Again, and for some clients with even anorexia, their safe food was baby food still, and of course that's a whole different issue, but they seem to not, lack a voice. And then clients that want potato chips and salty, savory food, they seem to have a lot more anxiety disorder, and they want something to crunch on, because they have all this anger or anxiety. So that definitely, unfortunately, especially in Arizona, it's not practical to carry on ice cream for 72 hours. I think that's going to open a whole can of worms with different things. But yes, it is very interesting, and sometimes that's how we find trauma too. So a client who doesn't present or share like sexual trauma, and then they won't eat bananas or Greek yogurt, especially because of the sour taste to it. So, and then again, that's where I go back to the therapist and report that to them, and it opens a dialogue.
I just wanted to comment on your comment about where do you stand on sugar. I've learned over time that it's probably dangerous for me to take a stand on anything, because I didn't think you could be addicted to sugar, and now there's interesting new brain science done by the same researchers I read 25 years ago as an addiction psychiatrist, exciting the dopamine pleasure centers and all the relationship to substance abuse that are the same pathways that are being lit up by obese people that struggle with. So there's more to come on food addiction. I think that's kind of an exciting new area to, I believe, just like in everything else, it's going to be two extremes, and most people will be in the middle, that some people will be more genetically set up to be predisposed to want certain types of food. And I think there'll be other people that will be the opposite, that will be all emotion. But most people will be somewhere in the middle with that complex interrelationship. But what I used to assume couldn't possibly exist, there's now evidence with science to show that it might and indeed does exist. So that's just an interesting area that I've read more and more about over the last year to get humble again, to think what I assume may not be the case once our science gets better to explain what's going on. So I do see people that come into Rosewood that are binge eaters or compulsive overeaters that I'm starting to say, this person's different than this person, so maybe this person does have a predisposition through some genetic addiction type component as opposed to the other person doesn't have that. It's going to be interesting to see where that goes. As a psychiatrist in eating disorder treatment, as people move to the outpatient setting, I'm really looking for stability in their mental status, but also that they're following the rest of the treatment plan. Because I learned early on that the doctor can have a lot of power. I can really undermine the rest of my team if I take control and say that this is the really important thing to get well. Taking this Prozac is really the most important thing that you do, and all of a sudden they stop going to the rest of the program. It's one of the reasons why, even though there's new medicines out there for alcoholism, Camprol and Naltrexone that have an effect in people that are working a good program, that are struggling, they can help. But I also could say, here, take this Naltrexone, and the person goes, oh, I don't need to go to my program anymore because the doctor gave me this medicine. So it's how you approach that as well, by educating the patient, saying, so I'm not, again, if I'm treating somebody with alcoholism, the first thing I think about is in Camprol. I'm asking, are you going to meetings? Are you talking to your sponsor? Are you going to your therapist? Are you dealing with your core issues? Are you praying and meditating in the morning? All the things that the fundamentals of recovery need to be. And then if they're doing all that, and they're saying, God, the craving for alcohol is really strong, I might consider adding Naltrexone or Camprol to what they're already doing. But I don't want to remove the power of the real work that they need to do that's fundamental to recovery. So I'm doing the same thing with eating disorders. You're doing your meal plan. Are you refraining from your behaviors? Are you, seeing your therapist? Are you staying present? Are you doing what you need to do, not doing the old behaviors? And then if they're on a psychiatric medication for a comorbid condition, I'm talking about that. And then if they're having substance abuse issues, I'm talking about that as well. But once I start to hear from other team members that the meal plan's falling by the wayside or whatever, I take my power away. So, well, there's no sense coming to see me if you're not feeding your brain the way it needs to be fed, because all the Prozac in the world's not going to work if you don't have serotonin in your brain. I'm just trying to rehash the importance of doing everything else so that what I do is important and helpful in the treatment. That's pretty much, again, the comorbid conditions, as I said, I'm just trying to treat everything effectively and making sure people are doing their program, if it includes other 12-step programs and so on. Mood and anxiety disorders that do exist are monitored, assessing ongoing, it's all basically good practice of maintenance to keep people moving in the right direction. And exercise, that's an important point. If a person starts to exercise before the team tells them to exercise, that's a warning sign. That's the person that leaves treatment 2 days early. They're already starting their relapse. Doc, I don't need 2 more days of treatment, even though their discharge date was set up to be that. Completion is really important. Person that starts sneaking out and exercising, there's evidence now that may be the first sign of relapse. So I'll have families ask me in the family program, how do we know when it's okay for our loved one to be exercising or when should be worried? I said, ask them if the treatment team said this is part of your treatment right now. If the treatment team is holding them back because they're afraid they're an exercise bulimic, compulsive over-exerciser, and they ignore that and go do it anyway, that's a real problem. And that might take them back to their disease. I tell my patients in regards to exercise is generally healthy for all of us that don't have eating disorders and it's not a sickness of. Just like a glass of red wine a day is healthy for our heart, but if you're an alcoholic, I wouldn't tell you to have a glass of red wine a day because I'd kill you with your other disease. So there are some people I do believe that may not be able to go back to exercise for an extended amount of time, and maybe even never. I don't know for sure, but I treat people that are so compulsively driven to exercise and count every calorie that it's like taking the alcoholic and walking into the bar and saying, you can have lunch here 2 days after they got out of rehab and you should be okay and not have to have a drink. It's just not going to happen. So it's all relative, because families go, but exercise is healthy. Well, yeah, so is a glass of red wine if you're not an alcoholic. Food's the best medicine. The malnourished state needs to be addressed, and accurate diagnosis leads to effective treatment. This rush to diagnosis, somebody goes into rehab and within 2 days they're diagnosed bipolar disorder when they've been using benzos and cocaine to go up and down. I personally have a real problem with that, because now you're starting people on a medicine that you don't even know that's necessary and has significant side effects, and the person doesn't even know what's going on with them, much less the doctors or the people that are treating them. So they might believe they do, but again, I was taught differently. Sit back, wait and see what evolves. If it's safe and the person's doing okay, don't rush to judgment. So, and you can't treat what you don't know. So if you don't have an accurate diagnosis, somebody's not going to be treated very effectively. And I think that's it. So,